term clinical examination comprises three essential processes: history taking, physical examination, and side room investigation. So let's deal with history taking. Two doctors performing clinical examinations on the same patient may come out with the same findings and yet come out with different histories. A good history constitutes 60 to 70% of the final diagnosis. The taking of an accurate and detailed history, however, comes with experience and repeated practice. Certain terms should be made clear from the onset. Like when you talk about symptoms, they are what the patient complains of. Example, cough, chest pains, breathlessness, easy fatigability. And when you talk about signs are what the examining doctor finds on the examining patient, like swollen leg, rash, a shriveled limb, or an irregular pulse. In taking the history, one must use language that is very simple and so easily understood by all. You have to build rapport. An accurate, neutral introduction should be made at the start of the interview, and the patient should be set at ease. In developing countries, most patients still regard doctors as powerful, all-knowing beings, and they are apprehensive when they come into contact with a doctor. So it is one's duty as a doctor to allay his fears and get him relaxed. In this relaxed atmosphere, one is likely to get all the necessary information that one is seeking. Be sensitive to the patient and let him feel that one cares. Give him time to express himself and explain what he feels is wrong with himself. This is the ideal situation, but in practice, one will either have to help the patient come out of what is wrong with him, and sometimes one has to curb a patient who is so very verbose and gives a lot of irrelevant and unnecessary details. Patients can be grouped into three main groups. There are patients that are so intelligent and business-like, straight to the point. Patient who gives a correct and detailed account of his illness without any emotion or hesitation and with little or no help from the doctor. The other patients that are shy, poor historian, who needs a lot of prompting and leading questions to get facts out of him. Thirdly, there are verbose, talkative patients who gives a lot of irrelevant information and who needs sympathetic guidance from the doctor to retrieve the important facts from the long story. Only practice and experience will tell one which patient one is dealing with and how much one should interfere to get the facts of the history. For presenting complaints, start with an open question such as what do you feel is wrong with yourself, or how did your illness begin, followed by what happened next, and give him time to answer the questions, to express himself freely. Ask about the duration of each complaint and let him expand each of the presented complaints. Most patients will require prompting to get all the facts one needs. Okay, for systemic inquiry, you make a systemic inquiry about the symptoms in other systems which the patient has failed to mention. So one will be surprised at the number of symptoms the patient will admit that he has got, even though he did not volunteer them earlier. Because patients may not remember everything that has happened to them, or may consider that what they do remember is irrelevant or too trivial to mention, it is permissible to jog their memory with some structured questions on each of the systems. So general health, you can ask about the weight, appetite, fever, sleep and mood. Or respiratory system, ask about cough, sputum production, chest pains, hemoptysis, breathlessness and wheeze. Cardiovascular system, ask about palpitations, breathlessness or lying flat, that is autopnea, chest pains, ankle swelling, paroxysmal nocturnal dyspnea, and tiredness. Also ask about exercise tolerance, for simple everyday things like climbing up a flight of stairs, or walking uphill, or even shaving in the mornings, and leg pains on exertion, alimentary canal, GIT. You can ask about conditions of the mouth, or bleeding gums, nausea, vomiting, bowel habits, and nature of stools. Ask about abdominal pains, difficulty with swallowing, belching, hematemesis, epigastric fullness, and flatus. And then ask about indigestion and weight loss, the color of stools, whether pale, dark, black, or bloody stool. And urinary system, ask about dysuria, polyuria, nocturia, oligouria, stress or urge incontinence, poor stream, and stress incontinence. Also ask about strangry, which is constant desire to urinate, although there is little or no urine to be voided. Ask about the frequency of nutrition, both during the day and during the night. The nervous system, ask about headache, numbness or tingling, muscle weakness, dizziness, vertigo, blackouts, fits, the sleep pattern, vision, double vision, syncope, hearing like deafness or tinnitus, and then disturbed sensations. So these symptoms need considerable amplification to make sure that a patient and the doctor mean the same thing. And also for genital system, you can ask about menarche, frequency and duration of periods, blood loss, example clots, flooding, are periods painful. Also ask about sexual activity, the libido, impotence, fertility, urethral and vaginal discharge, and post-menopausal bleeding. Locomotor system or musculoskeletal system, and ask about muscle pain and muscle weakness, stiffness and swelling of the joints. So if from the history any system is found to be the prime suspect, then one will need to expand on the subheadings. So if mental illness is deemed to play a part, then one will need to frame additional questions in this area. Okay, so drug history. One must then ask the patient if he's taking any drugs, either prescribed by a doctor or acquired by the patient himself. Ask about allergies or hypersensitivities to drugs, and take the patient's history of allergy serious, as patients have been known to die after they have been given a drug they are allergic to, even though they told the doctor about their allergy, but the doctor ignored the information. For past medical history, you now proceed by asking the patients about any past illness. Okay, so some patients would have forgotten, and one has to jog their memory by asking if they have ever been admitted to the hospital, and with what condition, and has he had any surgery in the past? If so, does he know what operation he had? For family history, ask about a family history of tuberculosis, diabetes mellitus, systemic hypertension, gout, arthritis, epilepsy, mental illness, and even coronary heart disease like myocardial infarction. So the presence of any of these illnesses in the family should increase one's awareness of the possibility of the disease being present in the patient. Also, information about the age and health or the cause of death of the patient's close relatives is often very, very valuable. For social history, ask about the home conditions, housing, occupation, interests, and habits. Ask about food, tobacco, and alcohol consumption. Tactful exploration of income and commitments can follow too, so together with the details of the educational background. One must then inquire in all cases about the occupational history, because some jobs can cause disease like iron deficiency anemia from hookworm infestations in farmers, Wells disease in sewage workers, mesothelioma in exposure to asbestos and dyestuffs, and even biocinosis in exposure to cotton dust. History of foreign travel should also be inquired. Certain tropical diseases like amoebiasis and malaria is acquired by living in endemic areas. Hence, any travel within and outside an area should be inquired about, as it may give a clue to the present illness. The importance of history of foreign travel or travel is demonstrated by the fact that certain diseases are endemic in certain areas, and one acquires a disease when one travels to that area. For example, if one wades through or swims in a river which is known to be infected with schistosomiasis, one can get the disease. Also, if one travels to an onchocerciasis endemic area, one can be bitten by the transmitting agent, that is Simulium damnosum, and one can acquire the disease. One must also ask of foreign travel, as a high percentage of people who have acquired HIV, that is human immunodeficiency virus, give a history of foreign travels. For psychological assessment, psychological factors affect both the patient handling the current illness as well as the outcome in all patients. So the account of the history, the manner it is delivered will reveal much about the patient's personality. When the physical examination reveals negative findings, then it becomes more important to get a more detailed psychological assessment. All diseases will influence the ability of the patient to return to work. Some disease job combinations will totally preclude a return to that occupation. Example, epilepsy in a pilot or heart attack in a driver of heavy load vehicles. History from a third party is sometimes very relevant. So in an unconscious patient, people who have had epilepsy or people with mental impairment, one has to depend on the history from a third person who can give an accurate account of what took place and the progress of the illness. Synthesis of the history. When the history has been taken to one's satisfaction, the first step has been taken to the diagnosis. So the information must now be appraised, taking into account the reliability of the patient, and then the relevant facts must be separated from the irrelevant facts and evaluated objectively. So at the end of the history, one must be able to find which system is involved in the disease process, and one must at this stage have an idea of the provisional diagnosis, of differential diagnosis, or be still undecided. So following the history, the examiner should proceed to physical examination to elicit the evidence, either to confirm or refute his provisional diagnosis based on the history. Sometimes the findings may point to a different direction altogether. It is important during the history taking that one looks at the patient all the time. This will help one to get the added evidence from the facial expression as well as the non-verbal communications from the face and gestures.